quiet mathematical crisis is unfolding in the dark reading rooms of modern hospitals. Every single year, the volume of medical imaging produced globally expands at an exponential rate, far outpacing the number of qualified human beings available to read those scans. It is a fundamental bottleneck in the healthcare ecosystem, where the sheer machinery of detection has completely outrun the human capacity for interpretation. To understand the severity of this bottleneck, look at the daily reality of a modern diagnostic radiologist. In some high-volume trauma centers and corporate imaging networks, a physician must analyze and interpret a new image every 3 to 4 seconds during a grueling 8-hour shift just to clear the daily queue. This relentless, factory-like pace pushes cognitive endurance to its absolute breaking point, leading directly to delayed diagnoses, missed subtle lesions, and severe physician burnout. There is a dark irony embedded in this rapid technological progress. As CT scanners and MRI machines become increasingly advanced, they generate many thousands of high-resolution slices per single scan instead of a few dozen. We have built the perfect high-fidelity tools to look deep inside the human body, but we have buried our most highly trained specialists under an avalanche of pixel data, making it exponentially harder to find the exact anomaly that threatens a patient's life. This unsustainable equation is forcing a massive structural pivot across the entire medical sector, driven by the rapid deployment of specialized artificial intelligence. Hospitals are not looking for autonomous robot doctors. They are deploying deep learning algorithms specifically designed to act as a highly efficient triage engine. These systems are built to serve as a tireless second set of eyes, engineered from the ground up to process massive data sets without ever suffering from visual fatigue or cognitive decline. In practice, this means AI analyzes complex X-ray scans and cross-sectional imaging the exact moment they leave the scanner, long before a human physician even opens the digital file. The algorithm instantly maps the pixels, searching for microscopic irregularities that match known historical pathologies. By the time the radiologist actually sits down at their workstation to review the case, the system has already flagged potential abnormalities for urgent, immediate review. The architecture driving this shift relies heavily on convolutional neural networks that have been rigorously trained on millions of carefully annotated images. These models do not simply memorize what a generic tumor looks like. They learn the underlying geometric and textural features of human anatomy across vast and diverse populations. By processing decades of historical diagnostic data, the deep learning engine builds a comprehensive, multidimensional mathematical map of both healthy tissue and fatal disease. Within this complex computational architecture, the AI operates in a latent space, where it can identify patterns that are entirely invisible to the naked human eye. It detects incredibly subtle gradients in tissue density or microscopic calcifications that might indicate early-stage malignancy. While a human relies on visual contrast and years of clinical intuition, the algorithm calculates statistical probabilities at a granular pixel-by-pixel level, fundamentally altering how anomalies are detected and categorized. This capability completely rewrites the traditional, antiquated workflow of clinical radiology. Historically, scans were read in a strict first-in, first-out sequence, meaning a critical brain hemorrhage might sit in a digital queue for hours behind dozens of routine ankle sprains. Now, the AI forces a dynamic, intelligently prioritized queue, pushing the most dangerous and time-sensitive cases to the very top of the radiologist's screen the moment the images are captured. Consider the immediate life-saving impact on lung cancer screening outcomes. Lung nodules are notoriously difficult to spot in their earliest, most treatable stages, often hiding behind ribs or overlapping blood vessels on a standard two-dimensional chest radiograph. AI models specifically trained for thoracic imaging can isolate these faint shadows, highlighting a suspected lesion months or even years before it would typically become symptomatic and dangerous to the patient. The ultimate metric for this technology is the dramatic and measurable reduction in time to treatment. When an algorithm flags a suspicious mass immediately, the clinical oncology team can order a biopsy and initiate a comprehensive treatment plan in a matter of days rather than weeks. In the field of oncology, where tumor growth is exponential and unpredictable, shaving weeks off the diagnostic timeline is often the difference between a curative procedure and palliative care. This dynamic proves that artificial intelligence serves best as a powerful force multiplier for human expertise rather than a wholesale replacement of the physician. By automating the tedious, time-consuming process of measuring benign cysts and sorting through perfectly normal scans, the technology returns massive amounts of cognitive bandwidth to the doctor. The radiologist is finally freed to focus their specialized medical training entirely on complex, ambiguous cases that require deep clinical judgment. True diagnostic accuracy in cancer screening is always a delicate, high-stakes balance of sensitivity and specificity. It is not enough to simply find every potential problem. The system must also confidently dismiss benign anomalies to avoid triggering unnecessary panic and highly invasive biopsies. The most advanced commercial models are now achieving this equilibrium, learning to ignore harmless scar tissue while aggressively flagging high-risk cellular growth with unprecedented precision. We see this balance clearly in the rapid evolution of breast cancer screening. Mammography generates an overwhelming volume of routine images, historically resulting in high rates of false positives that require painful and expensive follow-up procedures. By deploying AI as a concurrent digital reader, modern clinics are maintaining exceptional detection rates for invasive carcinomas, while significantly driving down the sheer volume of false alarms, directly improving the psychological and physical patient experience. The ripple effects of this operational efficiency extend deep into the economics and psychology of the broader healthcare system. Burnout rates among diagnostic radiologists have historically hovered near 50%, driven largely by the sheer volume of unread scans hanging over their heads like a pendulum. By clearing the backlog and acting as a highly reliable safety net, AI is stabilizing the medical workforce, improving physician retention, and lowering hospital liability costs. Yet integrating these advanced systems into the daily chaotic grind of modern medicine is not without significant friction. Many regional hospitals operate on legacy IT infrastructure, utilizing fragmented data silos and outdated image archiving systems that were never designed to communicate with high-speed neural networks. The core challenge is no longer about proving the algorithm works in a controlled lab. It is about forcing it to function seamlessly inside a massive, bureaucratic hospital network. To bypass these legacy bottlenecks, the medical imaging industry is shifting heavily toward cloud-based APIs and lightweight deployment models. Instead of requiring hospitals to install massive, expensive on-premise servers, imaging companies are routing securely anonymized pixel data to centralized processing hubs. This allows local clinics to leverage cutting-edge zero-shot inference capabilities, updating their diagnostic accuracy in real time as the central models continuously learn from new global data streams. As this technology scales across healthcare networks, the medical community must carefully navigate the psychological trap of automation bias. When an algorithm is right 99% of the time, humans naturally begin to defer to the machine, potentially losing their own critical edge over time. The real danger arises when a radiologist subconsciously stops looking for secondary fractures or rare tumors, simply because the AI bounding box did not explicitly highlight them on the screen. To counter this systemic risk, software developers are designing intuitive user interfaces that require active human engagement rather than passive, mindless approval. The AI might provide a detailed heat map of suspicious areas, but it strictly forces the physician to make the final diagnostic ruling before moving to the next patient file. This creates a collaborative synergy, ensuring that the machine augments human intuition rather than dulling the critical thinking of the medical professional. This collaborative, human-in-the-loop approach is heavily shaping regulatory frameworks across the globe. Agencies like the FDA are rapidly clearing AI medical software, but they are drawing very strict lines between tools that assist in diagnosis and systems that attempt to practice medicine autonomously. The regulatory consensus is clear. The algorithm is a highly sophisticated medical device, but the legal, ethical, and moral responsibility for patient outcomes remains firmly with the human doctor. Beyond the highly funded walls of elite research hospitals, this technology is driving a massive global democratization of medical expertise. Rural clinics and developing nations, which often lack any access to subspecialized diagnostic radiologists, can now plug directly into the same deep learning engines used by top-tier oncology centers. A chest X-ray taken in a remote village can be instantly analyzed with the same rigorous diagnostic accuracy as one taken in a major metropolitan hub. We are currently witnessing the fundamental redefinition of the radiologist's role in the modern intelligence era. The physician is transitioning from a high-speed pixel hunter into a strategic patient manager, utilizing algorithmic insights to guide incredibly complex treatment decisions. They are no longer simply reading static images. They are synthesizing AI-generated data with patient histories, genetic markers, and clinical symptoms to deliver highly personalized, incredibly precise medical care. Ultimately, the way AI is changing cancer screening outcomes comes down to the ruthless, uncompromising optimization of time. By conquering the massive crisis of volume, filtering out the visual noise, and prioritizing the most critical threats, artificial intelligence is giving doctors the one resource they desperately need. In the brutal fight against cancer, time is the absolute most valuable currency, and this technology is minting it by the hour to save human lives.